Hi, I am Alice Gallo. I'm an intensivist at Mayo Clinic in Rochester, Minnesota, and I'm honored that I get to talk to you about the failing liver and how we resuscitate it. I have no financial disclosures and no conflicts of interest, but I do need to say that I absolutely love the liver, and I think liver failure is one of the most beautiful physiological diseases that we treat as intensivists and emergency medicine physicians. And because we went to medical school to take care of people, I want to start with a case. So we're going to talk about a 32-year-old who came in saying, I look yellow, I have belly pain, and I can only sleep during the day and I stay awake the whole night. 6 weeks before they showed up, they had a URI. And since then, they have been having increase in abdominal girth, lower extremity edema, started a week before presentation bilaterally. And 2 weeks before they came to the ED, his wife noticed jaundice and change in circadian rhythm in the sense that he would only sleep during the day and he would pace the house at night. On exam, when I first saw him, he was tachycardic, hypotensive. His MAP was around 50, non-invasive MAP was around 50. He was jaundiced. He had painful abdominal distension without rebound tenderness. And like I said, he had bilateral lower extremity edema. So a little bit more history. He has alcohol abuse disorder. He told us that he was abstinent for 12 months. He's a former bodybuilder. He used over-the-counter supplements and pro-hormones, including steroid precursors. And he's currently on over-the-counter multivitamins, magnesium, vitamin D, and E. Formal medical history is just depression, and he is on duloxetine prescribed by his primary care. And he also had a gunshot wound, self-inflicted, to the chest when he was intoxicated 2 years before presentation, but that has healed. He needed surgery and had no major wounds except for sternum. These are his initial relevant labs, and you can see that he had hyponatremia, which is very common in liver failure. I just want to start talking about this right now. You can see that he also had acute kidney injury, and he had not seen any healthcare professionals since he had his gunshot wound in 2 years. So we don't know what the acuity of his renal failure. And you can see that his LFTs are only mildly elevated. But his INR is more than 20, and that was repeated, and that was more than 20 on repeat, so confirmed. So just for context, we have someone who comes in with altered mental status. He was having change in circadian rhythm, jaundice, and an elevated INR for at least 2 weeks. For the investigation, his path was 773. The reference is less than 10. And I just want to touch base on two things on path. If someone has a path of more than 80 nanograms per milliliter, they are heavily drinking. Our colleagues in liver transplant are using path to also help determining liver allocation. And path can be detected for 4 to 6 weeks after last alcohol intake. So again, this patient had told us that he was abstinent for 12 months. His wife thought he was, but the path told us different. And we also did autoimmune and viral hepatitis, and they were all negative. Again, we did because he was young, because his LFTs are not completely compatible with an acute autoimmune or viral hepatitis, because his LFTs will be much higher than they were. So just for you to see the point of care ultrasound of the abdomen, you can see there was some ascites there. We did do a point of care ultrasound of his heart, and it was just hyperdynamic. There was no valvular problems or anything. Didn't include here because it was just hyperdynamic. In the chest x-ray, like I mentioned before, you can see that he had the wires and because of his gunshot wound, but otherwise just low air movement. And abdominal x-ray, you can see distended bowels, and again, we wanted to make sure that we were not missing anything else other than ascites. So what is going on, and what would you do next? Again, this is a young man with altered mental status, elevated INR, jaundice, with known injury to the liver by a toxin, alcohol, and he's in liver failure. So just want to share with you the way I think about resuscitating failing livers, and in my brain is 10 things that we have to do every time we see someone who has failing liver. So early diagnosis, stabilize them, identify the cause and the timing, address that cause, think about fluids, because again, liver failure patients are a very unique population, hemodynamic support, manage coagulopathy, provide adequate nutrition, refer to transplantation as early as possible, and secondary survey. So early diagnosis. So first thing, definition, what you need is INR more than 1.5, any degree of hepatic encephalopathy. So again, change in circadian rhythm is hepatic encephalopathy, and prior diagnosis of liver disease will give you acute on chronic liver failure, and no prior diagnosis of liver disease is going to give you acute liver failure. Regardless, the management is the same. One thing very important, this patient didn't know that he had liver dysfunction, so acute liver failure. Timing of onset is very important, and that's why I emphasize so much that he had 2 weeks of changes, because that's gonna be correlated to prognosis as well. So if it's a hyperacute liver failure, patients usually do well. But if it's moderate, meaning 1 to 4 weeks, or subacute 4 to 12 weeks, these patients tend to do a little worse. And I have a QR code for you for the references for this slide. So stabilize is our classic ABC. So airway, we need to make sure that they have a patent airway. Sometimes these patients already come comatose from their hepatic encephalopathy, so make sure that they have a patent airway. If they don't, secure their airway soon. Breathing, same thing, oxygenation. They might have acute liver failure or acute on chronic liver failure from a pulmonary infection, so make sure that they are oxygenating well and ventilating well. And circulation, again, these patients, remember, they live in if they're chronic liver failure, they live in a constant state of sepsis, so we need to make sure that we address their circulation early and effectively. We're going to talk more about it. So 3 and 4, in terms of the commandments, identify and address the cause. So hepatic decompensation and organ failure in patients with pre-existing liver disease are most often triggered by an infection or use of toxins. And in many, many cases, the inciting event itself won't be identified. But think about causes. Think about why they are all of a sudden either decompensated or in acute liver failure without a known prior liver disease, and address the cause as soon as possible. Again, this patient, we believed it was because he was again binge drinking. So make sure that we give the best supportive care for potential withdrawal. If we thought this patient was infected, make sure that we start early antibiotics and broad, and make sure that we ask family about risk factors for Pseudomonas or MRSA, for example, so we can address those quickly. Other drugs also, over-the-counter, always ask about over-the-counter medications, and always ask about trips, because again, sometimes patients with chronic liver failure are already immunosuppressed because of the chronic liver failure, and they are exposed to bugs that are not common. So ask about exposures too. And acute on chronic liver failure is associated with high mortality, and acute liver failure is also associated with high mortality. But all data we have shows that if we recognize it early and address early, there is better prognosis. One very important thing that I need to touch on is the heterogeneity of definitions for acute on chronic liver failure. And you can see that the Asian Pacific Association for the Study of the Liver does make sure that you talk about 4 weeks by ascites and or encephalopathy, and a lot of other societies won't talk about ascites. They would just talk about altered mental status and INR and jaundice. Coagulopathy and jaundice, I'm sorry. If you see the European Association, they will just talk about acute deterioration and related to a precipitating event. But again, in a lot of times we can't find the precipitating event. And the North American Consortium just talks about acute deterioration. The most important thing is think about it. Okay, so think about it in someone who comes in jaundice with acute elevation of INR and altered mental status. And I just want to put a quick reminder of the precipitants of acute on chronic liver failure. Again, alcohol and toxins. Any toxins can precipitate acute on chronic liver failure in patients with chronic liver failure. Infections, any drugs. Don't forget GI bleed, ischemia, and thrombosis. Remember that these patients have a very impaired coagulation system, so they might be procoagulable at the same time that their INR is elevated because of all of the impairment of procoagulable and procoagulable proteins. Now let's think about fluids. Fluids in critical care and emergency medicine, I believe, are going to be the discussion of all our lifetime, and I think I'm going to retire in 20 years from now and we're still going to be talking about fluids. But as of today, there's no established colloid over crystalloid superiority to resuscitate patients in liver failure. Some studies, very small, favor albumin if serum albumin is less than 3 in patients with chronic liver failure. But again, very small studies, not randomized, just retrospective data. So today, if a patient comes in, needs resuscitation, crystalloids versus colloids, we don't have good data. One thing that is very important, lactate clearance is impaired, but lactate will still be cleared. You still need to look for lactate clearance even in patients with acute on chronic liver failure, because they will clear. It's just going to take them longer, but the goal is to clear. So again, if a patient comes in with acute on chronic liver failure, you think they're septic, or you think they have another reason for their acute on chronic liver dysfunction, they should clear their lactate. It might just take more than 2 or 3 hours, but they should still clear. If they're not clearing in 6, 12 hours, look for other causes for lactate elevation, such as bowel ischemia or any ischemia of anywhere. Hyponatremia is very common, and these patients are very delicate because if we give them 3% saline, they have more risk of developing refractory ascites in the days to come. So then it's going to become a vicious cycle. They develop ascites, we drain their ascites, and then we might put them into renal failure because we are having to drain their ascites so much. So for patients with liver dysfunction, 3% saline for hyponatremia should be given only if they are seizing, because they are encephalopathy, their change in mental status is most likely secondary to the liver dysfunction itself than the hyponatremia. And correcting the liver dysfunction will likely also correct their hyponatremia. Addressing any potential renal dysfunction with the liver dysfunction will also correct their hyponatremia. So again, for liver failure patients, if they are hyponatremic, 3% is only if they are seizing. Early pressors likely better. Same thing, the studies show for acute on chronic liver failure patients that norepinephrine still superior for any shock, second pressor, vasopressin. If you're thinking hepatorenal syndrome, which is again not the purpose of this particular lecture, but if you're thinking hepatorenal syndrome, the combination norepinephrine and vasopressin might be good from the get-go. This is a very important and dear figure for me, because we recently published this figure, me and my colleagues from hepatology here at Mayo Clinic, and in my opinion, this is one of the best figures I've seen to make sure that we think about every single organ dysfunction that can happen in patients with acute liver failure just because they are on acute liver failure. So again, for cardiovascular, think about splenic vasodilation, early pressors. For GI and nutrition, think about variceal bleeding. So if they had varices in the past, be mindful, be in the lookout for any GI bleed. Start them on PPI early. If they have GI bleed and you think it's from variceal bleeding, start octreotide early. Call your colleagues in endoscopy early so they can address this. Make sure that they are receiving thiamine and folate, because they are, again, chronically malnourished, very likely. Be on the lookout for refeeding syndrome when they are ready to get nutrition. Endocrine, remember, these patients with chronic liver failure are potentially in a very low state of adrenal insufficiency. So if they are in shock, consider early stress dose steroids. These patients also might present with hypoglycemia because their liver is so sick that they can no longer do glyconeogenesis. So be on the lookout if you have a patient with acute on chronic liver failure or acute liver failure and they are persistently hypoglycemic. You run to their bedside, you don't walk, because that means that their liver is really, really sick and really, really failing. Coagulation, like I mentioned before, they will have impairment of all their procoagulable proteins, and they might be procoagulable despite the fact that they have an INR of more than 20 in this case, for example. Tags are still controversial even in the liver literature. Tags are approved currently for liver transplant, intraoperative coagulation evaluation, and trauma coagulation evaluation. But for a patient who's in the ED or needing only the medical ICU, very controversial, the use of TAG to guide blood resuscitation, blood products resuscitation. But if a patient with liver failure is bleeding, always try to do 1-to-1 PRBCs and FFPs in addition to platelets and cryo, because again, these patients are very, their coagulation is very disturbed. Infection, again, address early. These patients have immunodeficiency just because they have liver disease. Think about Clostridium difficile. These patients, liver failure patients, usually have toxic megacolon from C. diff instead of diarrhea, so be mindful of that. If a patient is taking their lactulose and they're not pooping for a whole day, think about C. diff. And like I mentioned before, think about drug-resistant organisms because these patients are immunodeficient. Think about kidneys. Ascites can cause renal dysfunction because of extrinsic compression to the blood flow to the kidneys, and also because of splanchnic vasodilation, the kidneys won't get as much flow. And good old pulmonary, they can have infections, they can have pancreatitis, they can develop ARDS pretty quickly. In neurology, most common cause for brain dysfunction is going to be hepatic encephalopathy. So early lactulose when they come in, even if you have to put an NG tube to give them lactulose as well. And rifaximin in the last 2 years has become a great adjunct for the treatment of hepatic encephalopathy, but is very expensive. So be mindful of that. Liver transplantation evaluation. call your friends in liver transplant as early as possible. Again, nowadays, there's not a formal cutoff for age in terms of liver transplant. If a patient who is still drinking or still using drugs can show that they can have an excellent support from family post-transplant, they might be considered for transplant. And if it's an acute, so less than a week of acute liver failure that we can pinpoint to the timing, these patients do better also. So don't forget to call your liver transplant colleagues soon. And secondary survey, almost like trauma, you go back and you reevaluate all those organs again to make sure that we have the right antibiotics, the kidneys are being perfused, we have drain ascites to look for SBP and to give the kidneys a break as well in terms of intra-abdominal pressure. We have them on lung protective ventilation if they needed their airway protected. We have lactulose plus or minus rifaximin going. We are giving them appropriate nutrition with a little bit of protein and all the vitamins that they need. So again, secondary survey. Don't forget your prophylaxis in terms of antifungals and SBP prophylaxis if they didn't have SBP this time around. So my take-home points are: acute liver failure management should be systematic. So again, think about all the organs, and if you can, think about the figure that I showed a few minutes ago. Just keep that in your mind when you are at bedside in someone with a failing liver. Management of acute liver failure and acute on chronic liver failure should be supportive and targeted to each organ affected. Always the liver is a priority, but again, if other organs are failing, please target them. Infection and exposure to toxins are the most common causes for liver failure. Make sure you ask family about any exposures. Make sure you think about all of them. And transplantation referral should always be considered because, again, nowadays we don't have age cutoffs. We have a lot of mild exceptions. And if patients can show they can be supported, we have a lot of support to give them. And this is all I had for you. So thank you very much. For questions, please find me on social media. I am at Gallo de Moraes MD, both on Instagram and Twitter. And if you want to send me an email, I am gallodemoraes.alice@mayo.edu. So please reach out. And again, thank you so much for the opportunity.